coordinators and colleagues. I'll be taking practice question 3B, and the question reads thus: a 65-year-old man who weighs 97 kg with left leg pain swollen and was on ascending and descending the stairs is also a retired footballer who had left anterior cruciate ligament rupture 30 years ago and has been staying alone after his wife died 5 years ago. He's also a non-hypertensive diabetic who smokes 10 cigarettes a day and drinks alcohol. The patient is said to be afraid of taking dairy products. The follow-up questions were, what are the differentials? Then how would you investigate the differentials? What are the other X-ray features in this condition? What is your final diagnosis? What are the patient's risk factors for this condition? And mention 6 classes of drugs used in treatment. So this patient actually had a left knee, which was swollen and with associated pain, just only on one joint, or thinking more of a monoarticular pathology. And also, given the fact that this man has a history of previous trauma, his occupation as an ex-footballer, which is actually sporting activities with, they can have contacts or repeated injuries over time. Then his age, to increasing age and weight. Although would have loved to have his height to be able to calculate his BMI, but that weight seems to be a bit on the high side. It can predispose him to having osteoarthritis, putting osteoarthritis first as the top differential. Gouty arthritis also is also a differential, coupled with the fact that he's diabetic and also he takes alcohol. This can predispose him to having gouty arthritis. Rheumatoid arthritis is also a differential, but I will expect a symmetrical pattern here. Psoriatic arthritis also, they could have oligo, mono-oligo, or even poly arthritis. But here we'll still see some skin lesions too. Septic arthritis, the particular joint could be said to be on examination warm, hot as a result of infection with all these similar pains. But it's a differential to also reactive arthritis, bursitis, and this man typically scared of taking dairy products. So we'll still look at, maybe he has some poor intakes of calcium. It could have osteoporosis, which could have led to some other bone issues. So how will you investigate this patient? To investigate the differential, we can do an X-ray. This can typically help us differentiate a very close differential rheumatoid arthritis, whereby you typically will see erosions, and they are mostly symmetric with no osteophyte. Mind you, the erosions are very rare in osteoarthritis, only a particular primary type which has this erosive osteoarthritis, which is mostly found in the hands, but that's actually unilateral as against the rheumatoid arthritis that is symmetric. Then we could do the synovial fluid analysis, whereby we can do even for the culture, and if there are organisms, it might show markers of infection to rule out septic arthritis. Also coupled with fact with laboratory markers of infection, with full blood count, CRP, ASRO, which could promote a septic condition. Then even with the synovial fluid, we can also do the microscopy under polarized light, where we can see for gout the negative bifurcent needle-shaped crystals, and then pseudo gouts, the positive bifurcent calcium pyrophosphate crystals. MRI can give us similar findings like the X-ray, but it will be more elucidative, and it can even tell us about the bursitis, if there's bursitis. Then diagnostic markers we can use for rheumatoid arthritis, the anti-cyclic citrulated peptide that can be used, and rheumatoid factor can also be used to distinguish. Alongside some markers, you can do the HLA, DRO, 4 or B12 for rheumatoid arthritis, and for psoriatic arthritis, you can do the HLA B27 and CO6. That could help us. Then some metabolic disorders, even thyroid disorders too, have been associated with development of bone issues. So a thermography too can help us do that. Then a bone densitometry can help us for osteoporosis. Patient could also have other diseases that might really push for us to, that will warrant a bone scan like Paget's disease. It could even be a bone cancer as increasing age. So a bone scan too can help us with that. So what are the X-ray features that we'll see? We know the typical loss where we say there's loss of joint space. As we can see, I'm trying to see if I can put my, okay, when the loss of joint space, as you can see, the narrowing, which will lead to narrowing. Then if we look towards this place, osteophytes, these are osteophytes forming around. Then classically, over time, they can have the subchondral cysts. These are the ones that are hyperlucent here. And then the sclerosis, which are actually white here. So the osteophytes can be in various places, but for this particular patient, because it's the knee, they might have osteophytes coming from the tibia. Those that would actually cause all this deformity or instability in the joints. Those are called the tibia spikings. That could also be there. So what is your final diagnosis? Final diagnosis is osteoarthritis of the left knee. And we know it's one of the commonest articular disease worldwide. And the second to ischemic heart disease as cause of work disability in men mostly greater than 50, although women are mostly affected, and it accounts for 30% of physician visits and makes up 80% of patients in a rheumatology clinic in Nigeria. So what are the patient's risk factors for this condition? As said before, the risk factors in this patient include age, increasing age, the weight. We don't have the BMI, but definitely that weight is of 95 kg. It looks a bit high. We don't know the height. Repeated joint stress and previous joint injuries is also a possibility. Lifestyle, like cigarette smoking, excessive alcohol consumption, and also comorbidity, diabetes. It's been said that it's a secondary cause of osteoarthritis. So others include the gender, female, family history, genetic disorders that can increase the likelihood of osteoarthritis and also increase bone density. So mention 6 classes. 6 classes include analgesics, which could be simple analgesics like paracetamol, oral ones, or topical analgesics like capsaicin. Capsaicin mostly is used when so many others have failed in terms of pain management for osteoarthritis. You can also use NSAIDs, the opioids, the corticosteroids, even the intraarticular glucocorticoids. Antidepressants too can be used, tolozetine, and then viscose supplementation agent like hyaluronic acid. So the keynotes of note is the fact that the pathogenesis for osteoarthritis has changed over the years. Previously said to start from wear and tear phenomenon, but now it's been shown that it has both inflammatory and genetic component, most especially the neutrophils, although they might still look normal on the full blood count assay when we check. So it's a complex interaction between biomechanical, local tissue, cellular factors, soluble mediators, and genetics. Here, we have a quiescent. The cartilage typically is quiescent. It's not active. But due to this pressure, wear, and tear, they can become activated with release of all these chemokines and soluble mediators. And in a predisposed genetic background, osteoarthritis results. So this diagram just quickly talks about some of the pathophysiology as regards the symptoms that they will have. So with the repeated trauma, destruction of the subchondra, cartilage, they can have subchondral fractures, they can have synovial fluid being pushed away outside into the bone, and this can stimulate nociceptor receptors within the subchondral bone, and the patient has pain with the use of the joints. Also, with the aberrant deposition of bone formation, or in terms of trying to heal the subchondral osteophytes, they can cause destruction of the normal joint. You can see palpable bony hypertrophy, like in the butcher's node we see in the proximal and herbadine in the distal interphalangeal joints. This can ultimately result in disability, and we know that once the cartilage is lost, there's a grating sound when bone touch bone, of which we elicit as crepitus, and the joint movement reduces. When the location between them is reduced, it can cause joint instability and even reduce movement. So that's why they have pain in the motion and reduced range of motion, and sometimes the stiffness that they experience. And also ultimately, if the inflammatory parts is sensitized, there's increased secretion of proteolytic enzymes that can lead to joint effusion. All of this will reduce with increased risk of infection. So it can be classified into, based on etiology, based on primary, we check, and then secondary. As of note is the metabolic cause that we see here, diabetes, of which this patient also has. It could also be classified based on the type of pain as early, mid, and advanced. There's also a Kergrin classification that divides it into all the different parts of the body. Of note, I wanted to point out here is, just in case, typically they mix this with rheumatoid arthritis, of which we know some of all these are Boutonnet sign and Z-top sign. The first carpal metacarpal joint of the hand can also be affected by osteoarthritis, and it's called the shouldering or squaring of the thumb, whereby there's a subluxation of the first metacarpal, and you see the reduction of the space of the first metacarpal and the subluxation of the first metacarpal, as we can see in this diagram here. So this is the shouldering. It's as if, and it typically, we shouldn't confuse this with the Z thumb. So management, the principle actually is to reduce pain, enhance mobility, prevent deformity, and target modifiable risk factors. It's very possible if we can prevent some of all this. That's actually the aim of that would definitely be very, very good for them prior to getting this disease. So we target modifiable factors, very important. And we do this using a multidisciplinary approach where we have the rheumatologist, physiotherapists, occupational therapists, nutritionists, and even orthopedic surgeon when it's indicated. And the non-pharmacological, we've talked about the pharmacological. Non-pharmacological is actually the mainstay of management for osteoarthritis, actually coupled with the pain and tackling the pain. So non-pharmacological, you have to educate this patient very well. It's very important. And also weight loss, at least they should lose at least 10% of their body weight to maintain appropriate weight. Use of assist device, hydrotherapy, physical exercise. Of note, quadricep strengthening as aerobic exercise to help those joint stability. And you can also use therapeutic taping to tape the joints to balance it. This can significantly reduce pain. Infrared is used, popular, but is not effective. We can also do adjuvant therapy for these patients because they can become depressed, all lots of issues. So you want to manage depression and sleep issues, you can give them muscle relaxant. And then sometimes they can do arthroscopic tidal lavage and joint debridement, where arthroscopy will be used to debride the joint. Then indication for surgery include intractable pain, deformity, and disability. And the types of arthroscopic lavage could be either arthroplasty or osteotomy. So our take home is that osteoarthritis is very common. The osteoarthritis of the knee in particular is the commonest in women, and it's commonest worldwide. Commonestly affected joint is the knee, followed by the all over the world. But most studies in Nigeria will show both knee and hip. Management is multidisciplinary, and it's been shown that the vitamin D, glucosamine, sulfate, chondroitin supplementation have no efficacy in long onset, and the non-pharmacological therapies are the mainstay with concomitant pain control, and you have to refer early to rheumatology. So I just put this that we'll look at in terms of secretion, rheumatoid arthritis and osteoarthritis, gout and pseudo gout. These are my references. Thank you for listening.
Thank you so much, Dr. Momodu Jafaru, for that extensive and excellent presentation. Your effort is well appreciated. Okay, so it's time for questions and contributions. So while we wait for questions and contributions from the participants, I just want to do an add-on to what you just did. Okay, so for the differentials, we can also add traumatic arthritis. And then also for the drugs, hydroxyl and chloroquine has been said to play a role as well, and is classed as a steroid-sparing medication. Then lastly, we now have novel markers to actually check the progression of the disease. So these novel markers are the matrix and metalloproteinases. We also have the bone sialoproteins. And then we also have what we call the hyaluronan. And then lastly, we have what we call the cartilage oligometric matrix protein. So these are proteins we actually use to assess the progression of the disease. Okay, so that's basically what I have to say. That was a brilliant presentation. So I'm going to go into the chat room.
Thank you.
Okay, there's a hand up. So okay, I would want Dr. Muhammadu to please speak up. Thereafter, I'll go into the chat room to read the comments. Dr. Muhammadu, you can
Thank you very much, Dr. Momodu, for that wonderful presentation. I think the question has been excellently addressed. However, I have some few concerns from the question. You highlighted patient is afraid of taking dairy products. So I wanted to find out what are the possibilities that you intend on, what is the importance of that dairy product, especially in this patient. And secondly, in the evaluation, I have not seen you requesting for serum uric acid, which is very important, especially in this patient. Then also some of the inflammatory markers that you have been, especially in those inflammatory conditions, which ones are reliably used in the osteoarthritis by this case. Thirdly, this is patient that his wife died, and probably looking at the 5 years ago, and looking at the age 97 years. So I think some of the geriatric complication also should be entertained. At least one or two should be entertained as a possibility, especially in his condition that is still not improving despite the medical illness. So I think those are my few comments and questions. Thank you.
Okay, thank you so much, sir, for the question. Actually, for this patient who has comorbidities, is actually having also a lifestyle which might be actually due to maybe his wife loss, being alone, and it might point towards him not eating very well. And also, we know calcium is a very important source, most especially for bone density and the bone health entirely. So this patient, also considering the fact that he's elderly, what was on my mind was it has increased risk for either osteoporosis. And that's why I put that as a differential there, which doesn't have a direct relationship to osteoarthritis, but it could also uh, make his quality of life poor in terms of if there's osteoporosis happening in this. That's what I thought there. Then for the
Let me address that.
okay,
There are a lot of research that have shown avoiding dairy products, especially in elderly patients, tend to reduce their pain. It tends to reduce inflammation and pain in their joints. I have been trying to see whether I can get it, but probably if I get it, I will share it to group.
okay,
But avoiding dairy products tend to lessen joint pain, many joint pain, both the small and the big joint. So that's why he's
okay,
avoiding it. And secondly, also
okay,
you mentioned avoiding it may actually predispose him to low calcium, and so that one is another explanation. But the most important explanation is avoiding dairy product in elderly patients tend to lessen their joint pain, and because it reduces inflammation around the joint pain.
okay. Thank you so much. I came across something like that for women. They said they had lower progression of osteoarthritis who drank milk, but I didn't get a complete this. It wasn't really. I didn't know it was backed by evidence. I will be so happy to have that. Thank you so much. Then for your second question, you talked about the inflammatory markers too for the osteoarthritis. Apologies on that. I think the question just wanted me to differentiate some of my differentials from osteoarthritis. I think that's why I didn't go as far as putting some of those inflammatory markers. However, I should have added the uric acid too for the gout, which is quite essential. And I tried making some of the very important inflammatory markers just to um, help out the CRP, ESR. I don't know if that suffices or you want to add more. I'll be glad to do that. Then the last question, I really didn't get the comorbidities. For this particular set of questions, the management entirely for this patient wasn't a key point. I just added some things behind, but even as much as that, that will be under adjuvant therapy, whereby you have to look into some of the process or the effect of the osteoarthritis on the individual. So as far as an elderly too, if we even look at it, this patient will also need a comprehensive geriatric assessment. Here is even alone, so we can even have some other things like elderly neglect. Why will he be alone like this? He should have children. He's 65. He's been a retired footballer. So comprehensive geriatric assessment could also come in here to actually delineate all the problems in this man and actually get the best care for him, alongside managing that likely depression it might be having, and also to correct cognitive behavioral therapy to correct these lifestyles from smoking to alcohol. I don't know if that suffices. Thank you.
Okay, thank you so much, Dr. Muhammadu, for that input, that great input. Thank you so much. I can also see the electronic hand of Dr. Aminu Bashiru. Dr. Aminu, please, you can speak up. Thank you.
Good morning, everyone. Thank you very much, Dr. Muhammadu, for that beautiful presentation. Yes, some of what I intended to deposit has just been said by Dr. Muhammad Sani Enzu. So, additionally, while you're just trying to differentiate your main differential diagnosis from others, yes, the inflammatory markers, just as it has been mentioned, while you're trying to rule out that of rheumatoid arthritis, it will be of good to add anti-CCP, the anti-cyclic citrullinated peptide, which has been shown to be almost 98% positive in those people that have rheumatoid arthritis, to differentiate it from this. Then, please, emphasis is also supposed to be made in the management. He has to stop smoking. He has to stop consumption of alcohol. I think all that's has rightly been well addressed by you. And by and large, it's a very beautiful presentation. Thank you very much.
Thank you, sir.
Thank you so much, Dr. Aminu, for your comments. Well appreciated. So I'm going into the chat room now. Okay, so in the chat room, Dr. Ola Itan Abimbola is saying, thank you for the lucid presentation. Investigation should include uric acid level and serum calcium. I guess that has been addressed. Thank you so much, Dr. Abimbola. Dr. Brown and Binky, Becky, Aga, Paul, Ekeli, Rita, Michael, as well as Maduka. And then Dr. John is saying excellent knee can also be done to rule out knee effusion. Thank you so much, Dr. John, for that, your great contribution. Okay, so Dr. Shamshuddin, Dr. Anthony Geoffrey, Yayaha are all applauding you for a great presentation. Okay, so Dr. Jamila is saying, thank you very much for the wonderful presentation, Dr. Momodu. After the last presentation on osteoarthritis, I went to look for more risk factors for osteoarthritis and didn't come across smoking as a risk factor. Checked many articles. Latest was 2023, and none mentioned smoking as a risk factor. Thank you so much. Okay, so Dr. Momodu, what's your take on this, please?
Okay, thank you so much. So much research has been done ongoing, and there's been contrasting, contradicting, or also complementing inflammatory conditions or processes that can lead to inflammation. One is smoking, two is alcohol. And it's been said that these particular mechanisms initiate the inflammatory components too that can affect the joints. So that's why they are independent risk factors. Unlike the secondary etiology or secondary causal factors like diabetes, where there is a linear relationship to where you have reactive oxygen species distress that they can increase on the joints from the metabolic interplay. So in terms of the inflammatory aspect too. So those ones are well established, but smoking, alcohol too, they have contrasting and contrasting views. But it's actually a risk factor too. Is there risk smoking and alcohol? Thank you.
Okay, thank you so much, Dr. Mamodu. Okay, so Dr. Christian Ade is saying, thanks for an excellent presentation, Dr. Jafaru. I believe the osteoporosis is a long stretch of the differential diagnosis, and maybe we should remove it. Osteoporosis does not cause localized pain unless there's fragility, fracture. So, Dr. Mamodu, what's your take on this?
Okay, thank you so much. I really was trying to spread my net because of this dairy products of a thing. And I know that osteoarthritis can affect any joint. In short, any joint of the body is quite degenerative. But the commonest ones are the large joints that we see, all those knee and the rest. And they could have pain anywhere. So I just felt in the entirety. That's why it's the last of my differentials down. So I just wanted to put it in entirety in terms of the um, differentials. But if the house feels that it shouldn't be there, I wouldn't mind taking it down. Or if there's a rheumatologist that can help us push it more, I wouldn't mind taking it down. But I just felt that I shouldn't leave that untouched because of an information there, of which I also just got now, that actually reduces the inflammation, is confirmed that it reduces the flares for the osteoarthritis. Thank you, ma.
Okay, thank you. Okay, so I'm seeing an electronic hand of Dr. Omo Kwowa. Please, you can speak up. Thank you.
Okay, good morning, ma. Good morning, Dr. Kalamama. Good morning, our teachers, and thank you, Dr. Jafar. I am a rheumatologist, so let me start by saying that osteoporosis is actually in order in this differential. You may just put it as osteoporotic fracture instead of simply saying osteoporosis, and that makes it okay. Yeah. So the other comments I have, a lot of comments have been made. I won't just repeat anything that has been said. So the under differential that could have been considered if we're looking at the knee alone, given the patient's age, the presence of diabetes, and some of the features in the X-ray, is CPPD, that's calcium pyrophosphate deposition disease, which has many presentations. But one of the things that could have been considered here is CPPD. Okay, then some of the differentials you had, I feel maybe you could have maybe defended them more from the information in the history. For example, the septic arthritis, given father is elderly and diabetic, is a bit immunopyretic. That could lend credence to septic arthritis. For the secondary causes of OA, there are much more. DM is one of them. You mentioned thyroid disorders, especially hypothyroidism, acromegaly, Cushing syndrome. So this can all come hyperparathyroidism. And then if you want to stretch it, assuming, for example, there was some evidence of renal impairment, then you could also even consider renal osteodystrophy. So the other thing I'm going to say is that the question actually talks about the leg and not just the knee. But so the differentials could also include differentials of bone pain. Some of them were mentioned. I just wanted to just point out that this question talks about leg pain and the leg is swollen, but they gave a knee X-ray. So if you don't look at it entirely, you tend to focus on knee pain, which is correct, but not the entire question. So if you consider a left swollen leg that is painful, then other differentials may come in. some of the ones that are important, you mentioned Paget's disease. That's very important. And then you talked about doing a bone scan, but you could also do simple alkaline phosphatase, even though we have a lot of tests around the world. But alkaline phosphatase is still the gold standard for making the diagnosis and then for even monitoring the progress. There are other more sophisticated tests. The bone scans, that's the bone isotope scans are there. Bone densitometry is there for other causes of osteoporosis, including Paget's as well. But ALP is still very important. And then in that line, investigating the bone, another differential you want to consider is vitamin D deficiency. Many studies are showing that the risk is actually increased with Africans and Blacks, as contrary to what was previously thought. And so they can have hypocalcemia, hypophosphatemia, increased alkaline phosphatase, reduced vitamin D levels, and increased parathyroid hormone levels because of secondary hyperparathyroidism. So these are some of the other things to consider. In terms of treatments, I would say that maybe some of the drug classes could have been maybe put in a different way. Maybe it's so that you have more options. The drug options that are really approved for OA, depending on which guideline you're using, are rather limited. So expand the options. So simple analgesics, acetaminophen, NSAIDs, which could be given either intramuscularly, orally, or even topically. Intra-articular corticosteroids, yes, but not any other form for OA. So somebody mentioned steroid-sparing therapies. Some of them are used in OA, but they are not used as steroid-sparing therapies. When you talk about steroid-sparing therapies in rheumatology, it means that you're giving the steroids for a prolonged period, and you want to reduce or eliminate the steroids from the regimen. And that's why you're introducing on that drug. So we're not really giving steroid-sparing therapy in OA because we don't give steroids in OA for a long time. The only way we give them in OA is to just intraarticularly to solve an acute pain problem. Now, some of the drugs we use as steroid-sparing therapies in other conditions can be used in certain forms of OA. And a good example is hydroxychloroquine and then methotrexate. And these are used, as far as I know, specifically for hand OA and not just for any other form of OA. So I think that's in order. And then muscle relaxants, talked about opioids, specifically tramadol, and then antidepressants, specifically duloxetine and amitriptyline. Then the muscle relaxants like tizanidine, baclofen, we also use. And then importantly, when all measures are failing, there are severe deformities, which can further worsen the pain and progression in OA. We also do joint, we refer to the orthopedics for surgery. And also when there's such a degree of pain that the quality of life is severely compromised. For example, if a patient is sleeping at night and still in severe pain, even when sleeping, that's very bad. And then it could be an indication to refer for surgery. Finally, the outcomes and the treatment paradigms in OA are shifting towards embracing a biopsychosocial model of treatment even more. So many of the outcomes now are being measured in terms of pain, function, how much the individual can do, how much the individual cannot do because of the pain in different joints. Quality of life. These are this is where treatment of OA is heading. And like you correctly said, there's a lot of emphasis on non-pharmacological approaches. Thank you very much.
Thank you so much, Dr. Omokowa, for that brilliant inputs. We want to be hearing
just say
more.
Dr. Sekame. We know him as Dr. Sekame.
Okay. Thank you, Dr. Sekame. Thank you. Well appreciated. We appreciate your great and impactful inputs. Thank you. Okay, so in the absence of further questions and contributions from our participants, I'll hand over to our Chief Christabel. Thank you.
Thank you so much, Dr. Kalamama. Thank you. Wonderful. Dr. Mamoudou Daforo, as expected, we didn't expect anything less than this. Always coming with your A-game. Thank you. That was a wonderful presentation. Quite lucid, straight to the point, focus and detail. Thank you. Dr. Sekeme, I appreciate you as always. Thank you. You didn't allow us to have to drag you out because really I went to the participant looking for you, and on your own you came out. That's something I've always appreciated about you. Always willing to share, always willing to teach. Thank you so much. Thank you, Dr. Sekame, for that wonderful contribution. Please help us plead with the other rheumatologists. I think you're the rheumatologist on ground now. Help us plead with the others to come in so that some of these tips and tricks in rheumatology will get to know about them, because when a specialist speaks, it's usually very different, really. A specialist is a specialist. There are some nitty-gritty fine details that a specialist will just draw attention to. And that is it. When you start saying this, we're like, wow, this is moving stuff. Wow, this is good. Person must have been trained well. They don't know that it was just an rheumatologist that pointed in that direction. So thank you so much, Sekeme, for coming. Dr. Mamudu, thank you. I don't know if any of our teachers have any comments. Chief Kuke, Chitu, Remigus, Fatima, Hokopi, Dahatu, Success, Atta, Yahaya. Any comments? Dr. Kayode, long time. I can see him in class. Good morning, brother. Thank you for coming to class. Dr. Kopi. Any comment, Dr. Atta? That's all.
Good morning, Dr. Christopher.
Morning, sir.
How are you? So that question, I think
Okay.
the red herring in that question is left leg pain, not left knee pain. And if we're just looking at left leg pain, there are so many other things. So left leg pain, swollen, that's actually I feel as if there's a problem with it, because if we're just considering left leg pain, you have to start thinking of things like cellulitis, pyomyositis, DVT, there's still so many other things that one can think of in this patient. It's just that the subsequent information kind of made it look as if it's more of a joint problem. So I don't know if one should just consider the joint issues or just look at other things apart from the joint. Okay, so I don't know if some other people who were present have a clearer understanding of picture of whether it's just the joint they were talking about or the leg as a whole. Thank you.
Hello, sir. I think I'll just I don't know if those are waiting for the exam. I don't think any of them are in class. I don't think so.
We can discuss.
I think Dr. Asekeme can still come in here. But one good thing about West Africa exam is that you see all your questions at once. So that will guide you. So because the exam is quite fast, so you don't want to waste your time on unnecessary things, really. You have to be really focused. I think I also saw this question on West Africa exam. It's true. You have to be really focused. I think I saw this particular question. I was focused on the joint, on the knee joint, because they give you everything. The pictures, everything is there. So you see it. So you put all of this information together and answer the question. So I didn't even bother with the leg pain. I just focused on the knee. All my differentials was on the knee. And I think I got quite a good score, because I was peeping at the booklet. I got maximum scores for some of the questions. So I believe in the exam, we don't know what any of the exams you're faced with. If it's an exam where you see all the questions, you put everything together. That's why you usually advise you do not rush to answer questions. You consider everything. Just quickly put down important points. Focus. Just say, this is what I'm going to talk about. So once you start talking, you just keep looking at what you've written and you answer your question. So if you see something, a picture, everything is on joint and they're telling you leg pain, please just focus on, because if you start going about leg pain, you just lose focus. So my advice is, if they're showing a picture of joint, of knee, please focus on the knee. That's what I advise. What you can do for your differentials, if you are finished with all the other knee differentials for knee pain, what you can do is bring in the others down. But you should be saying things more like OA, osteoarthritis, rheumatoid arthritis, gout, pseudo gout, all those ones first. You should say all those ones first, reactive arthritis, before you start talking about Baker cyst and all those other cellulitis and all. You finish all those joint areas first. But I don't know, our second man is a rheumatologist. Don't know if he has any, if he has any comment. Dr. Tito.
Thank you. I don't know the intent behind the question, but I would just say that if you need differentials, in the second of this question, maybe you can start from the knee and work outwards. But sometimes they are really interrelated, more interrelated than we may know. For example, the Baker cyst is actually a common complication of many knee joint problems, including osteoarthritis, gout. And when it ruptures, it can cause leg swelling that can easily be confused with a DVT. And then likewise, you have things like Paget's can cause secondary osteoarthritis. So really, and they can cause bone pain in the tibia. Yeah. So really, start from the knee, but don't maybe deprive yourself of differentials, maybe because of the way the question is structured. Thank you.
So thank you so much. Not to waste our time, from what we have said, and what Dr. Second have also said, please focus on the knee, then go down to other differentials. Remember, it's just A. You have the S, and you have to be really fast. And you must, some of these marks are quite elite, 0.5, 0.25. You understand? So you really have to speak fast. There's no time to focus on one question and leave the others. I would really advise if you can give like 5, 6 differentials quickly, move to your B, finish that one quickly, move to your C, finish everything. Then you come back and say, sir, please, can I add to my difference? If you want to make it 20, make sure you've answered your question first. Not that you sit in a differentials, you are giving them 100 and you've not answered B, C, D. So that's also what I would say on this thing. So thank you so much, everyone. That was quite an interactive session, and we really always appreciate interactive sessions. So thank you so much, Dr. Sekeme, for coming in. Dr. Mamudu, we appreciate you. Thank you so much. Thank you. Dr.
Okay, thank you. Okay, thank you so much, Dr. Mamodu, once more again. Dr. Mamodu, please, can you unshare your slide?
Thank you.
Okay, so the next presenter is going to be Dr. Ekele Roberts. She'll be taking us on practice question 4A. Dr. Ekele, you can please have the floor. You have 10 minutes to present. Thereafter, questions and contributions will come in. Thank you.
All right, thank you so much. Good morning, my teachers and colleagues. I'll be taking practice question 4A. And the question reads thus: a farmer presents with a day history of the image shown following walking in the bush. The image showed left leg with blisters and blood stain on the floor, and then with reduced output. I didn't actually see the pictures, I just got this. So the other questions are: what is the likely diagnosis? Mention 5 other clinical features. Mention 5 possible complications, and then outline your management in the emergency. Okay, so my likely diagnosis, I talked about snake bite with envenomation and maybe possible AKI because it's a farmer, which is a risk factor. He was walking along a bush path. That's a risk factor for snake bite. And then he had blisters on the leg and then blood stain, which is showing a sign of severe envenomation, and then reduced output, even if I didn't say it was oliguria or anuria. That's why I thought of possible AKI. Then mention other clinical features. So apart from the local features that he presented with the blisters, for a patient with snake bite, they could have edema at the bite site. There could be erythema, painful regional lymph nodes, could be oozing from the wound, tenderness and differential warmth at the bite site, then fang marks, scratches, bullae, even extravasation of blood, like in those patients. They could also have other systemic features like nausea, vomiting, diarrhea, diaphoresis, fever. Some of them could present with chest pain, hematemesis, difficulty breathing, which is patients may have, even if they didn't mention them. And it's good to also watch out for neurologic symptoms like confusion or altered mental status, paresthesias. Some patients may present with ptosis, diplopia, dysphagia, the artery, excessive salivation, and then some paralysis of skeletal or smooth muscle. Some of them could have a weakness holding their head, or even trismus. It will present with when on examination hypotension, you check the pulse, could get peak arrhythmias. The eyes, they could have keratoconjunctivitis, conjunctivitis, corneal abrasion, ulceration, could even lead to temporary or permanent blindness. Okay. Some of them could have a history of changing urine color, and then spontaneous bleeding and even DIC. So the C question mentioned 5 possible complications. Apart from the AKI, they could have compartment syndrome, gangrene and limb loss. They could develop sepsis, severe bleeding. They could come in shock. They could develop respiratory failure from the respiratory muscle paralysis, and then visual damage. Okay, so now your management in the emergency. So when the patient presents, to do an ABCD of resuscitation, where you have to ensure that the patient's airway is patent, patient is breathing, then check the pulse rate, the blood pressure, that they're normal, or if the patient will need fluid or maybe nootropic agents, check for disability, expose the patients properly and examine for other bite sites if they are. Then you quickly do a 20-minute whole blood test. If it's impaired, you have to administer the antivenom, and then if I repeat after 6 hours, if it's still impaired, you can repeat your antivenom. So the one that's recommended to be used in this part of the world is the Equitab plus ICP, because they're trivalent antivenom against the most common species in sub-Saharan Africa. Talking about the Echis ocellatus, Bitis aeratans, and Najan Recollis. So you're supposed to be given intravenously and slowly. And then while you give, you observe the patient for an anaphylactic shock, which should be treated immediately with IM epinephrine. And then the dose you give depends on the manufacturer's instruction and then the severity of the envenomation in the patient before you, like this patient, I think this patient has severe envenomation because of the bleeding. So some, sorry to say, you can give 5 vials for mild cases, 5 to 10 vials for moderate cases, and then severe you can give up to 20 vials, but one, as I said, can give up to 30 vials, depending on the patient. And then ideally, should be given within 4 hours, but as when the patient presents, should administer the antivenom as quick as possible. Okay, so when you administer the antivenom, you should watch out for complications, because some patients could react. They could have an early allergic reaction, like anaphylaxis I mentioned earlier, and then you treat with epinephrine, or late reactions, which like serum sickness, which could occur 1 to 2 weeks later. So while you're managing the patients, good to ask where the bite occurred, if they have a picture of a snake, any previous history of snake bites, and then the symptoms present, what did they do before they came to the hospital? Depending on the presentation of the patient, you may need to use a multidisciplinary management approach. Like this patient may need a nephrologist, and then if the patient has some respiratory compromised pulmonologist, the anesthetist, or the surgeon CTS in case of compartment syndrome, and then other supportive care like fluid resuscitation. In this patient that has reduced urine output, he will benefit from fluids and input-output monitoring, can give anti-tetanus toxoid. If the SpO2 is less than 94%, can give oxygen, and if the patient has severe respiratory distress and need intubation, then you have to manage in the ICU. So in case of extensive tissue necrosis, you may want to give prophylactic antibiotics, although not required all the time. Then clean the wound. Investigations that you may want to do apart from the 20-minute whole blood test. So depending on the patient's presentation, you may want to do a full blood count, PT-INR, APTT, fibrinogen and fibrin degradation products, D-dimer, urine microscopy, serum creatine kinase. For this patient, you really need an EUC, serum electrolyte urea creatinine, calcium phosphate. We want to do uric acid and liver function test. Then depending on the presentation, you may want to do a chest X-ray if he presents with difficulty in breathing. If he presents with altered mental status, you may want to do a CT scan, and depending on the extent of affectation of a limb, you may want to do an X-ray of the limb. Okay, surgical intervention may be necessary. In case of paralysis from neuromuscular blockade, you may want to give neostigmine. And then if the patient is still bleeding after 1 to 2 hours, or the 20-minute whole blood clotting test is not normal after 6 hours, you may want to repeat the dose. And then all patients should be kept for at least 24 hours or until they are clinically stable by the physician's judgment. And then even after the patient is has stabilized, it's good to watch out for symptoms of re-envenomation, because it may occur, especially in patients who were hypotensive and then became euvolemic. They may have some symptoms of re-envenomation. And then before you start patients, it's good to counsel the patients about avoiding future occurrences. For this patient that is a farmer and is at risk, should avoid handling snakes. Or who try that, maybe to kill the snake. They should wear protective clothing and shoes, maybe like boots when they're walking around. Should avoid walking around and putting hands in dark places. And then if they have to sleep outside, they should sleep off the ground. And then also counsel about pre-hospital care in case future occurrences. Take the patient to a safe place, kill the snake if possible, and don't touch, because even a recently killed snake can re-envenomate. Immobilize the affected limb, get to the hospital fast, and then avoid some traditional methods of treatment, like using tourniquet, making incision, or trying to solve shock. Okay, I got this one. To immobilize the affected limb, no tourniquet, no electrotherapy, no cutting, no pressure immobilization. Reassure the patient, because not all the bites are venomous. Then immobilize the limb the same way you will immobilize a fracture. Get to the hospital quickly, and then tell the doctor of any symptoms the patient may have manifested along the way. So just to mention a few more things about snake bites, more common in Asia, especially the southern parts where you have India, even in Africa, especially sub-Saharan Africa, then Latin America, especially Brazil, where you have up to 400 species of snakes. The common families of venomous snakes include the Elapidae. We have the Asian and African cobras. That's talking about the Naja negricollis, then the Viperidae. We have the vipers and the adders, rattlesnakes, the Colubridae, Actra speedidae, and stiletto snake. Then you have okay. So these are risk factors for snake bite. Then the pathophysiology, the patient's presentation depends on the composition of the venom, the species, the age and size of the snake, even the amount of the venom injected, even the location. Those in the head and neck are more dangerous than the number of bites. And then the general condition of the patient, like it's worse in children and pregnant women. And then the venom is good to note that it doesn't consist of a single toxin. In fact, some literature will call it a soup of antigens. Contains more than 100 different components, and these are some of them enzymes known as amytic polypeptides, even some of them contain neurotoxins, like the elapids are both neurotoxic and hematotoxic. And then the Viperidae, they are cytotoxic and hematotoxic. So the severity will be minimal, will be mild envenomation when the local damage extends several centimeters from the bite side all the way to a major joint, but there are no lab abnormalities or systemic symptoms. Moderate when it extends beyond 2 joints with non-life-threatening systemic symptoms, and then severe when there are life-threatening systemic symptoms like airway swelling, also paralysis and bleeding. Okay, so these are some differentials, which depends on the presentation of the patient. So your goals of treatment will be to neutralize the circulating venom, to alleviate the pain, prevent paralysis, and then minimize tissue damage and correct any hematologic toxicity. The principles of management will be to recognize and correct any immediate life-threatening conditions, administer the antivenom, provide analgesia, then assess for local and systemic toxicity and correct them accordingly, then minimize harm from unnecessary and potentially dangerous interventions. The prognosis is usually good with prompt treatments. The patient is able to get to the hospital fast and then is able to receive the antivenom. But potential reasons for increased mortality include insufficient anti-snake venom, big product, then geographically inappropriate anti-snake venom, and then delayed treatment. And then other poor prognostic factors will include children, pregnant women, development of AKI, on lab lab results, low platelets, leukocytosis, abnormal coagulation, and then increased creatine kinase, or development of very rare and unusual features such as adrenal insufficiency, severe hypertension, or intracranial hemorrhage, acute angiography, and boil ischemia. So this is kind of like a severity scoring system for snake bites when we look at it later. Then chronic complications include non-healing chronic ulcers and amputations. And then patients who have AKI may develop CKD thereafter. So prevention, I've talked about this to avoid handling the snakes. Thank you so much for your attention. These are my references.
Thank you so much, Dr. Ekele Roberts, for that lucid and brilliant presentation. Your efforts is highly appreciated. Okay, so it's time for questions, contributions. So while we wait for questions and contributions, okay, like in the snake envenoming, we try to avoid analgesics like the NSAIDs, and the reason being because it can actually compound the venous-induced coagulopathies. That's if the patient comes analgesics like NSAIDs because it will worsen it. Then secondly, we should avoid even high medication come down with coagulopathy. So much, Dr. Ekele, for that excellent presentation. So going into the chat room, Dr. Abimbola, Dr. Regina Wiki, Dr. Becky, Obasi, Dr. Paul Mwanta, Dr. Blessing Amadi, Dr. and Dr. all of them are applauding you for an lecture. So I'm not seeing any electronic hand up, and no further questions. So I think you must have touched every part. You must have addressed every part brilliantly for questions. And thanks for the wonderful presentation, Dr. Olajumoke. Thanks for the wonderful presentation. High costs of antivenom is a disadvantage for the patient. Thank you so much, Dr. Jimmy. Dr. Afolabi Michael, so Basha, as well as Dr. Momodu are all applauding you for a lucid presentation. Thank you everyone for your beautiful comments. Thank you once more again, Dr. Ekele, for that excellent presentation. So in the absence of further questions and contributions, I would hand over to my chief.
Dr. Kalamama, thank you. The network is really poor today. Thank you so much. Thank you. Dr. Ekele, what more can I say? Thank you so much. That was wonderful. That was really wonderful. Thank you, thank you, thank you. I didn't expect anything less, by the way. Thank you so much. I don't know if any of our chiefs have any comments. If Ramigos, Chitu, Koke, Okopi, Fatima, Dahatu, yes, Dahatu is in class. Dahatu, yeah, infectious disease specialist. Dahatu is in class. Success. Any comment from our teachers?
Good
Any
morning,
comment? Morning. Dr. Dahatu, any comment? This is your area.
Yes, good morning, ma.
We can hear you. You can go ahead, please.
So my network is, I think I may not be able to say much thing, but I think she tried. The presentation is good and she has touched most of the areas. Those some part of the presentation, the network kept logging me out and in and out. So I don't know if he mentioned something like
The Heart network is terrible. We lost him. Network is terrible. So thank you, Dr. Ekele. Thank you so much. It's 8 o'clock. If there are no more comments from our teachers, I'll call on Chief Chitu. Tomorrow is Friday. Today is Friday. Tomorrow is Saturday to close the class. Once again, Dr. Kede, thank you. Dr. Kalamama, thank you. Dr. Momodu, we appreciate both presenters today. You guys did wonderfully well. Thank you, thank you, thank you. Dr. Temitokbe, thank you so much. Our class rep. We appreciate everyone's presence. Chief Chitu, sir, can come
Good morning,
close the class.
Okay, good morning, Dr. Christopher. In case you don't hear me for a second, my network is doing the same thing that Dr. Dahatuzon is doing. So it keeps switching off and switching on. Yeah. So it's been another wonderful day. Snake bites, like I always point out, is do not go for that exam without knowing snake bite inside out, because you will not forgive yourself. One question over the years that keeps coming back over and over again. So please, let's ensure we make sure we cover all our corners when we're talking about snake bite. You should know everything about it. Okay, tomorrow is our